Hi there. I'm here to talk about the discussion for this week, which is regarding how nursing theory relates and guides clinical care and that intersection. So, the article that I looked at most was written by Neil McRae, and its title is Wither Nursing Model: The Value of Nursing Theory in the Context of Evidence-Based Practice and Multidisciplinary Health. So, this article really highlighted the role that nursing model has uh, in adhering to evidence-based practice, and it highlighted that there is a gap between theory and actual practice. And the theory is intended to help guide practice, but there's limitations to how um, a theory can be implemented into actual clinical care. And this article highlights that nurse educators and nurse practitioners have the highest responsibility for guiding that we follow evidence-based practice, and then um, bedside nursing will follow, especially with the course of like educators. Um, they'll be able to follow the guidelines more easily. And just to talk a little bit about so how does this theory make a difference in clinical care? I think, well, how does theory, not this theory, how does theory in general? So there's many different theories, and uh, I feel that they make a big difference with guiding the practice, especially for how a nurse is going to interact with a patient. There's several social considerations for like the impact of culture and how we approach discussing what's most important to the patient, uh, as well as evidence-based practice for varying theories such as eras or enhanced recovery after surgery. So that guideline highlights early nutrition, early ambulation, nausea and vomiting management, and patient and family education, as well as multimodal and analgesia, or different ways of managing pain with multiple uses. So maybe Tylenol and ibuprofen and oxycodone, and alternating them to minimize breakthrough pain. So I just highlighted ERAS, which is a great theory. How is ERAS able to be implemented in actual practice? Um, it's going to depend on the floor and a lot on nurse educators and nurse supervisors for encouraging following evidence-based practice. So there's evidence. ERAS is very well supported as evidence-based practice for optimal healing following surgery. There's other theories you can follow as well, but ERAS is a very well supported theory for increasing patient outcome, where their pain is well managed more quickly versus staying in bed and decreased food or like waiting to eat. Um, and so on an actual clinical floor, it it may be difficult to follow eras if your floor isn't set up well. If you have a patient post surgery that just came back, but you have a heavy workload where you have three other patients, and they come back at 9 o'clock because their surgery was at 6, and it was a quick maybe it was a quick C-section, so they're back on the floor at the same time as other high responsibilities that you have. If the floor's not set up well, it's not that it's not set up well, but guiding nursing to have support on the floor. Maybe the charge nurse says, "Hey, I'm going to do your med passes for you so you can speak with the patient," or they're waking up now. We want let's encourage to get them up to at least to walk to the bathroom even if they can't go. So early ambulation, and having checkpoints for knowing what should I be doing and at what timeline. And I've even seen things on the computer on the corner for other like evidence-based practice, such as like, did you chart eyes and nose, and having a little sticker on the corner to because monitoring intake and output for cardiac patients is very important because the kidneys and the heart are linked. That's just one example. So I think that theory should guide clinical practice, and you'll be able to see. So how would you know when the theory is guiding the practice? I think you'll see this when nurses are able to um, follow evidence-based practice and when they're well educated on it, because theories change, or an organization might change. So maybe Aurora wasn't following ERAs. It wasn't what they were following initially, but after your floor manager read a really great article and they're like, you know what, we have lots of post-op patients, we're going to prioritize this. So then there's education during the staff meeting of, hey, this is a new priority and this is what it's going to look like. These are the checklists of what we want to try to do. And then also between the nurse manager and the nurse educator, encouraging that they truly understand it and understand why. There's a lot of responsibilities for bedside nurses. You often have at least 3, if not 4 or 5, maybe even 6 patients, depending on your floor. You need to pass meds, you need to ensure that they're eating. You might not have aides. Sometimes there are CNAs or other aides available, but not every floor has it. And it can be difficult to balance everything, especially when you don't know what's the highest priority. So, and ensuring that your patient workload is appropriate. If you have 3 post-op patients, it's going to be difficult to do all of the things for each of these patients. So discussing with your floor manager the workload, or if someone is in need of more critical care, talking about them being in the ICU, or if someone's on call. That isn't always possible, but advocating for what you can reasonably do, I think, is a great way to be able to follow the theory, because if you have too much on your plate or asking for help from the charge nurse, maybe the charge nurse only has two, so they can help you with ambulating your patient because you also need to do, or they can do your med pass so you can ambulate with them. Many things. And lastly, how could a theory in the clinical setting impact nursing quality, safety, and patient outcome? I've highlighted patient outcome, that evidence-based practice, that it is proven to improve patient outcome, and that is there's been testing on it, and these articles that you read, if we're able to follow the guidelines, it doesn't guarantee that every patient will have the best outcome, but it increases the probability that they'll have a better outcome. Often pain is better, like for example, of the ERAs, pain is often better managed. They're able to discharge quicker, and they may, oftentimes, it's not every single patient, but and they often have a better understanding of what they need to do to heal. The patient education starts right off the bat, and you are really reminding them and working with them as much as you can so that they understand what they need to do for themselves and how they're going to get better. And it's involving the patient. And as well as safety, you do evidence-based practice. There's lots of things for safety. So for ERAs, if your patient is post-op, they had abdominal surgery, they don't usually use a walker, but you're concerned about their stability, having them use a walker the first time they get up might be the best option, or at least a gait belt, because they feel unsteady, or maybe they're in more pain than they expected. So you only walk 5 feet to the bathroom, even though this patient may normally be doing laps in the hallway. But following surgery, they're not back to where they were. Also talking to them about these safety things as you're doing them, and explaining, you're not going to be using a walker forever. We're using this temporarily because of this. I want to make sure that you're safe. Once you're a little more steady on your feet, we can move on to no walker. And as well as nursing quality, it is a heavy workload to follow nursing theory and guidelines, and there's a heavy workload of nurses in general. But I feel that being able to follow evidence-based practice, the nurse often feels more confident in the care that they're providing if the educator really discusses it with them. And it may increase the work of what they need to do. So I think, using the people around you for support. I feel that following evidence-based practice improves nursing quality because we're able to understand why are we providing this care, what is it going to improve, and why is it a priority. Those are all important to me when I am considering what cares I'm doing for a patient, and it helps me provide the best quality care that I can for my patients. Okay, thank you for your time.